morning. It's our great honor to show you this lab case. I'd like to invite Dr. Xiangqi to give you a case introduction for this patient. Doctor, please.
Good morning, honorable expert. It's my pleasure to show the patient's information. Patient, 83 years old, mate, recurrent chest tightness and shoulder breathless for 2 months. Risk factor essential hypertension, chronic kidney disease. Left test result showed low eGFR, high BNP. ECG showed atrial fibrillation, ST depression in left V2 defined. UCG shows moderate tricuspid regurgitation and low ejection fraction value. We diagnose the patient is coronary artery disease, heart failure, atrial fibrillation, essential hypertension, chronic kidney disease. Next. The patient did a CAG half years old. We see the LAO, the cranial position shows the proximal and the middle segment of RCA is a serious nasal lesion accompanied with a serious calcified lesion. Next. We show the caudal and cranial position shows the LCS is total occlusion. And the proximal and the middle segment of LED is a serious nasal lesion accompanied with severe to moderate calcified lesion. And the first diagnosis also is a serious nasal lesion. Next. The operator chose down the LCA CTO used DCB. The size is 2.25 and the length is 30 millimeters because the LCS size is small. Next. Also, we calculate the syntactic score tool to evaluate the risk stratification. We find that the syntactic score is very high, and the cabbage is suitable for this patient. However, the patient's age is very high, and he is reluctant to accept the cabbage. Thus, the PCI is our choice. Next. This time, the patient has symptoms. So what is our strategy? Cardiovascular, RCA, and LED, LB support, imaging-guided PCI errors, or OCT, rotatherectomy, or the combination with intravascular liposome. That's all. Thank you.
Very clear case introduction. I think we show you our today's corneal angiography. Okay, just give us the first picture. Just concern the patient's the very complex conferences. The patient is 83 years old with the very bad cardiac function and also has the renal function efficient. So we just use the very several pictures to show the patient's today's coronary anatomy. It's the cranial visual very clearly. This also very diffuse the lung lesion, just extend from the proximal LAD and extend to the distal LAD with the big angulation, and you can see from just from the angio very severe calcified. And unfortunately, we find the previously PCI vessel, the circumflex, re-occluded again. But fortunately, it's not the dominant vessel. And ICA, you can see very clearly from the LAO cranial and the LAO view and the LAO cranial view, and also the very diffuse lung lesion from the proximal ICA to the middle ICA, and also with the heavy certified view from the angiography. And this patient, as you know, with the very high syntax score, is the high risk level patient, and the lesion, also the trapped vessel disease, very complex. So definitely is the chief case. So just like Dr. Wu have told us how to perform the PCI for today's case, because the patient has no chance for the CABG, and the patient family strongly refused the CABG, the open chest surgery. So PCI is our only choice, LAD or the ICA, because I think the circumflex there is useless for this patient. Even we recanalize again the circumflex. because the patient's the bad condition, we just concerned with our team and with our chief. I think ICA is right dominant. First PCI ICA will be safe and efficient, which will give the good support for the next PCI for the LAD. If today we just want to perform the LAD PCI, so we may need the mechanical circumambulatory device assistant like impeller and or the ECMO. Although we don't have the impeller in Chinese market, we have the ECMO here, but the patients has the multi-organ disease. I don't think ECMO is our initial choice. So today, our PCI strategy, we just want to PCI the ICA. And ICA, we just use the IABP standby. I think that's enough. Before that, please show me the LAO cranial view, please. We just use the transradial approach and use the 7 French guiding catheter is the SAL 0.75, and it runs through wire. And the wire next please. Wire easily next please. The wire very easily go to the distal ICA, but you can see the IVUS. Why we choose IVUS? Absolutely, the patient has the renal function, not good renal function, and not good cardiac function. So OCT is not our preferable. IVUS, I think, is probable for this case. You can see IVUS catheter cannot pass through. So chief next, we decide to perform the rotational atherectomy for this case. That's what we want to do next. And Dr. Penton, will you show the first IVUS image?
Lumen is very small, so the IVUS cannot do the distal RCA. So we check IVUS from the proximal. And here we can see the proximal vessel diameter is about 3.5 millimeter. And here the calcification angle is about more than 300 degrees. So go and pull back. We can see the calcification angle is about 180 degrees. So go and pull back. This is the proximal RCA. This is the leaflet plaque. And then go on here, near the guiding, we can see the vessel diameter is just 2.7 millimeter. Then go and pull back, the vessel is about 3.5. Okay, this is the baseline IVUS imaging.
So, based on the IVUS and angio result, even though you cannot push the IVUS catheter distally, why you choose the rota first, or why you cannot use the balloon, small balloon, to predilate? Some experts like to use a 2O balloon to predilate with a mid or lower pressure. If there is found the balloon full expansion, we can check the IVUS again to show IVUS rota or not. Okay, so before rota, you will check the ACT routinely or not?
We have checked the ACT. ACT 320.
Okay.
Seconds. Yeah.
Okay. So you can go ahead. Go ahead in the rota.
Okay.
This is a 1.5 burr. What's the initial speed of the burr of the rota?
Chief, I like to start with the 160.
160?
High speed platform.
Okay.
So I will deliver the burr 1.5. Okay. Low speed mode.
It's low speed. Low speed.
Okay, go.
Yes. The before rota we also can
60 solent.
No, stop. Okay. Use the RCA angel.
Please give us the
zoom
frozen
there. RCA angel. Zoom there. No. Freeze.
Previously.
Yes.
This one. Okay, this one.
Okay.
Reference.
No. Not
give
better.
Us a clearly view.
Yeah. You may make sure the rota distance from here or to there. Yes.
Yes. Well, so we will start. Is the high speed?
Yes.
Yeah, this is high speed.
Yes.
Okay, we'll perform the first rota.
150,000. Move 170, 170,000. Okay.
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 Just encounter very strong resistance.
So during the rotor procedure, we should pay attention to the heart rate and the blood pressure.
Yeah, blood pressure is okay. No EKG changes since now. The high speed mode, okay.
High speed.
Okay, increase the speed.
Okay.
Okay.
160,000.
Enough.
5 seconds. 10 seconds.
Okay, I can see some movement. Yeah. We
15,000.
just can see the advancement of the burr.
16.
15.
No, increase the speed.
So Chief, you can see a bit movement.
Yes, we can see the rotor burr move a little distantly.
Yeah.
Yes, we can see it. Just because severe calcification maybe over 270 degree, just because calcification was very diffuse. So we can perform the rotor for several times. Still pay attention to the heart pressure. The patient's heart rate and the blood pressure. The heart rate and blood pressure was very stable. Okay, we can rotor for several times.
Okay.
Just because before the procedure we check the SCT over 300, that's enough safety for the rotor procedure.
Okay, maybe the final round. Okay.
Okay. 150,000.
So there's no resistance and there's no speed deceleration, right?
10 seconds.
Okay.
We should make sure there's the speed low and the speed down less than 5,000.
Yeah.
Okay.
5,000.
So we can finish the first whole procedure
Low
of the
speed.
rotor with a 1.5 bar. Then we check the IVUS. Well, so Dr. Pan, could you tell me where's the severe calcification location? I mean the position. 钙化最重的地方在哪儿
It's here. This
The
point.
length of the severe calcification to the osteo RCA.
Okay, please inflate.
开口的距离多长
Okay, go up 12, 12, 16.
16.
Okay, done.
Okay.
Yeah, seems it works, Chief. This is a
22.
3 NC balloon.
22.
Yeah.
Yeah.
Okay.
12.
12. 16. 16.
16.
Okay, done.
Okay.
Yeah, it works. Go.
12.
16.
15.
Okay, done. Go.
12.
16.
15.
Okay, seems okay.
Okay.
Done.
Okay.
Okay, once more.
12. 16.
16.
Okay.
Okay, done. So Chief, the 3.0 works very well. And just because the reference diameter here more than 3.5, I like to use the
Now check the IVUS. We will see there is crack of the calcification.
Okay.
Okay.
IVUS again.
Even though just because IVUS cannot tell us the calcification is thickness, we don't know which is better, NC balloon or IVL.
Okay, 3.5, right?
Yeah, 3.5.
Okay. Lesion length. Or nearly 60, right? Okay,
Yeah,
two stents to understand. Okay.
Yeah.
So Chief, I think the preparation is very is enough. I like to deploy the stent. 3.5 for the first one. Okay, good. Yeah, go. Just go. Go. No, not picture. Go. Just to can choose the
8.
contrast volume. Okay.
8.
Done. Done. Once more, going up to 12. 12. Okay, done. Yeah, nominal pressure to deploy the stent. I will dilate the overlap side. Okay, go. Going up to 12.
12.
Yeah, 12.
Okay.
Okay, seems good. Expand very well. Yeah, right. No, I don't need test.
Okay.
Okay, give me another. Maybe give me 4. How about Dr. Pan? Proximal segment 4. Do you think
Yeah,
it's
4,
okay?
4.
Okay, 4. Yeah, the same length.
So check the first round of the proximate RCA or second round.
The
Yes,
second round
proximal.
is proximal.
Okay.
So I
So
think.
the landing zoom of the proximal part of.
So I think the 3.5 is better.
So if I use the 4.0 along stand, I just use the low pressure to deploy.
So the landing zoom of the proximal part of the RCA is what's the length of the proximal landing zoom to the austere RCA? Proximal landing zoom. 就你
给
关开口多远
？Just maybe 5 millimeter.
Okay.
5 millimeter. The chief, I will just use low pressure to deploy the 4.0 stand, just to avoid the complication of the standing. Please prepare the 3.5 and the 4.0 NC balloon. Okay. No. No contrast. Okay. Here. Test, please. Test, please. Okay. Test, please. Yeah. Proximal. Okay. Go.
12.
Yeah. Going up to 10. 10 enough. 10 enough.
10. Okay. 10.
Okay. Done. Okay. Done.
Okay.
Done. Yeah. Here. Going back to 10.
10.
20.
20.
Okay. Done. Done. Okay. Give me the 3.5 NC balloon. So I will give the picture just after standing. Okay, seems good.
That's why we want to combine the cutting balloon with rotor. If we use the NC balloon to post a predilation after rotor, we cannot make multiple crack of the calcification.
20.
If we use a cutting balloon, we can make a lot of multiple crack of the calcification compared with NC balloon. That's why we want to always use the rotor combined with cutting.
20, 22, 22. Okay.
Yeah.
One more again. One more again.
One more again.
Yeah. 20.
20.
Okay, now it's the 3.5 NC balloon. Just inflate at the 22 atmosphere. Okay, done. Yeah. Okay. 20. Okay, 22.
20.
22. Okay, done.
Okay.
Done.
We don't want to use a smaller balloon to predilate the lesion. After that, we put a larger stent. Sometimes we find after standing, we find the stent on dysfunction, even though the bailout strategy was very, very limited.
So that's what you teach us always, that use the big size balloon to predilate.
Not
to prepare.
Just one-to-one NC balloon. One-to-one NC
okay.
balloon. Even though we find the crack, multiple crack, or maybe single cracked, one-to-one NC balloon.
Okay.
Predilate. After that, we put the same size of the stent. Okay.
Thank you.